This conference will now be recorded.
Greetings, everybody. This is November 14th, Tuesday evening on the East Coast. This is our advanced recurrent prostate cancer group, AnCan group, and it's our Tuesday meeting of the week. And my name is Peter Kafka. I'll be moderating tonight. Uh, Now from Maui, Hawaii. It's good to be back home. Finally got some rain last night, which felt good. It's actually cool tonight, this afternoon. Almost have to wear socks. Anyway, it's good to be back here. Welcome, everybody. Oh, Rick says it's King Charles's birthday, too.
Yep.
I have to send him a card.
I always the thing that stands out about King Charles to me was when I was pretty young and a fan of Mad Magazine. They always made a big point of making it of pointing out how similar Prince Charles looked to Alfred E. Newman.
He did too.
He did, yes. Anyway, that always stuck with me. I don't think they look the same anymore, but anyway.
No, but he did when he was younger.
Yes, he did.
Well, Alfred E. Newman doesn't look the same anymore either.
No, he doesn't. But Mad Magazine still looks the same. Anyway, good to have everybody on board. So let me make a shout out to our sponsors quickly. Some of them have re-upped, some of them have not, but the ones on my list include Bayer, Pfizer, Myovant, Blue Earth, Myriad Genetics, Telix, Foundation Medicine, and Janssen, part of Johnson & Johnson. Anyway, we're thankful for their support and their recognition that peer support groups are of value. It's not only research and the technical end of medicine, but the peer support that has increasing value to all of us, and we could all testify to that, I'm sure. I know it's been essential for me over the years. So welcome, everybody. This is my second night in a row moderating. Last night I moderated the low and intermediate, which I've been doing for quite a while now, actually. Maybe 8 years, 9 years, something like that. I can't remember. Even though my cancer doesn't fall into that category, I kind of raised my hand years ago, and when it was still the Reluctant Brotherhood, and took on the moderating of that group, and it continues, and I'm happy for it. We had a very interesting session yesterday. Some odd things that don't often come up in our group here, relative in one particular situation to genetic profiling. People with low-grade disease knowing that they're a BRCA mutation individual, and what the implications of that are. You don't want to, even though you might have very low-grade cancer, you just don't want to turn your back on it. So just because people are low and intermediate or even active surveillance, you don't want to ignore this disease, because it can creep up in very strange ways and get misdiagnosed or underdiagnosed. And we all probably have been through a little bit of that in different ways. And we probably have some great stories to tell. So quite a few of you asked to speak, and I think we will fill our time up pretty easily. So let's start with Dr. Jeff. He was the first one on. So wherever that sunny beach is that you're speaking from, let's hear from you.
No, I didn't want to speak, Peter. Peter, I didn't ask for any time.
Oh, I thought you did say you had something you wanted to bring up.
No. I said I'll just hang out. I'm fine tonight. Thank you. Thanks.
Oh, okay. Okay.
Okay.
Well, if something comes up, let us know. Vic,
Sure.
let's go to Vic.
Well, hold on. Was that Jack who just responded to us or Dr. Jeff?
I thought that was Jeff.
No, that was, that was, no, you said,
Oh, what
Dr.
happened?
Ken.
Oh, sorry, miscue. Jeff, you had something, yes?
Yes.
Okay, sorry. I,
So
I
two quick
missed
things.
that one.
One is, and it probably won't apply to many, but when we get new people, it might very well apply. And that is lining up for the radiation treatments and the need to have a full bladder for the treatment. And it's probably the most difficult part of undergoing 48 treatments is holding the urine, especially when the machine goes down or somebody doesn't have enough urine in their bladder and they have to drink, you have to wait. The longer you wait, I don't have to tell anybody here, the more difficult it is. So I had this discussion with my urologist, and he gave me, and I mentioned this last week, a drug called Gemtesa, Gemtesa. Generically, it's Vibagron. Take one, it lasts 24 hours. And since I started taking it, which was about a week ago, I can honestly say I don't have that urge to urinate, and I don't go through that extreme distress of feeling like I'm going to urinate on the table because I'm holding a volume of urine. It really makes a difference. It's known as a beta 3 agonist. It relaxes the muscle of the bladder. It allows more urine to sit in the bladder, and it's infinitely more comfortable. So I just thought I would share that in case any of you know guys who really are struggling. Now, I can tell you the guys that wait with me, everybody struggles and everybody is complaining how difficult this is to hold the urine for extended periods of time. Okay,
How far in advance do you need to take it?
well, it's last 24 hours, so I've been taking it about 7 or 8 at night. And I've also noticed I don't get up as much. Maybe I get up once now as getting up 3 or 4 times. So as a side benefit, it's helped me with that too. But I'm mainly taking it so that when I go for the radiation, I'm not really struggling to hold a bladder full of urine. So my opinion, it's worth taking, and I only have another 17 treatments, so I have to take it maybe another 20 days, 18 days. It's not going to be a lifelong drug.
Are there any other side effects that you notice with it?
I haven't had any. They talk about urinary retention as a possible side effect. It hasn't happened. I'm urinating normally. So I haven't seen anything negative since I've taken it only a week, but I'm sharing it because if any of you are going through it or know anybody who is, it might be worth taking a course of this drug.
And it's a prescription drug, I imagine, yes?
Yeah.
Yes, 75
Sounds,
milligrams by prescription.
sounds great, Jeff.
Alan, go ahead.
Okay, what was the name of the drug again?
Gemtesa, Gemtesa,
Thank you.
one
No,
a
as long
day.
as long as we're
there's
on this
no,
topic, what got me through my radiation was a Lunderg clamp. And once I got the clamp, I didn't worry about urinating at all. And when I got the radiation was done, I'd take that clamp off and just let it go.
Huh.
wow.
That's what got me through. And I drink 40 ounces of water, every morning before the radiation. And if I didn't have the clamp, I couldn't do it. I just couldn't do it. And the hospital gave me a clamp that was shitty, and I went and got my own that worked. So just another option.
Right.
Somebody else wanted to speak. Who's that?
I
Richard.
just,
Richard.
Prior to my diagnosis, I had accepted a job with Myriad, which is the manufacturer of Vibragon, and it got its clinical approval for overactive bladder. And Jeff, as you just said, it's a very, very successful drug, and it does its job. But with my diagnosis, I couldn't continue in the role of selling the product.
Interesting.
Why was that?
So you were actually promoting this drug? Is that what you're saying?
Well, I had just accepted the job prior to my diagnosis, and 2 weeks in, after all of my issues, I was 2 weeks into training and just couldn't continue. And I would have been promoting the drug, yes.
I see. Oh. And Dr. Jeff, why do you think it's not pushed widely by radiologists?
I don't know. The first onco-radiologist I spoke to, he wanted to give me like atropine-like drugs, and I told him not interested. Then I would be at high risk for urinary retention. So it impressed me that he was about 10 years behind. This drug, as you correctly said, it was developed for overactive bladder. People who are just going all the time. Well, that's me drinking water for the radiation. And so perfect fit. And I would recommend it I have already, to the other men sitting in the waiting room who are really uncomfortable. So just sharing, it's anecdotal, but it seems to have helped me a lot.
Is it used for incontinence much?
Well, it increases the bladder capacity. So the bladder it relaxes the bladder, and you can hold more urine in the bladder without getting that urge to go. And it does work well. I do not have that urge to go with the same amount of water drinking.
So
Peter,
I guess, go ahead. Yeah, go ahead,
the
Richard.
incontinence piece is something that they had been working on. They hadn't gotten FDA approval for that modality to be used in incontinence, but that's one of the target areas that they're looking at. And to kind of address your question about radiologists not knowing, I think that hadn't been one of the call points of urology has been the call point for that drug. So maybe that's something they need to look at. Was talking with radiologists about it also.
Interesting. Yeah, I don't know. With incontinence, I don't know whether it would work for that or not, or whether you just still get leakage or even more leakage. So I don't know how that would work.
I could say something about incontinence since I was the
Yeah,
king of
yeah.
incontinence for about a year and a half. I didn't find that being incontinent was in any way related to the capacity of my bladder because I simply leaked a lot. I had held it for a little while, but I was always leaking. It was always damp in my shorts. It was always, dribbles here and dribbles there. And I could hold it. I never had the experience Alan had where he's talking about having a clamp to keep him from leaking or from actually, going. For me, the radiation was very uncomfortable because of the feeling of the full bladder got to be really, really, tough. And maybe Dr. Jeff, what you're saying, I don't know if you're saying that it kept you from actually going, involuntarily in your pants. I think you're talking about is keeping you from being supremely uncomfortable on the table.
Yes, just
And it is,
being
if it's very
uncomfortable.
valuable for that. I tried oxybutynin and a couple of other drugs to try to cure my frequency. None of them worked. And what happened, even after I got the artificial urinary sphincter, is I was still so habituated to go all the time that I settled into a pattern of 90 minutes of sleep at a time, which pretty much holds to this day. And it doesn't matter how full or how empty my bladder is. That's how conditioned I've become. Sad to say, but at least, sometimes when you have no answer, acceptance kicks in and you just sleep 90 minutes at a time. Sorry I have to do that, but, it's different for everyone, I'm sure.
The other
Well,
thing,
this is,
Peter, I just wanted to quickly comment on is this. So I sit in the waiting room. I don't tell people who I meet that I'm a physician. We're there for treatment and we talk. And there's at any given time 4 or 5 guys. There's new guys coming in. There's other guys who are finishing their radiation therapies. And I chat with them and then I say, well, what was your Gleason score? What is that? I don't really know. Or what kind of biopsy did you have? I don't know. A biopsy and kinds of things that men in this group are very fluent and educated about. Yet from the cross section of guys that I've come across, I would say 85% of them have no basic clue of any results, pertinent, important results, PSMA, PET scan results, PSAs, Gleason scores. They don't know what any about anything. And I'm shocked by this, that of the ignorance I'm coming across of guys like us who need to know these things. And I'm shocked.
It's a excellent point. I mean, it does. I don't think it surprises any of us, but I mean, the general attitude is, I mean, culturally, that whatever you say, doc, sign me up. You know,
It's a male
9:30 in the
thing.
morning, I'll be there. Just tell me where to go.
Right.
Yeah.
Yeah, one guy told me today, he said, well, I believe 100%. If my doctor told me to run through that wall, I would run through that wall. And he's 91 years old. I said, maybe you should just walk up to the wall. But it's really sad, though, that we're going through these invasive procedures with results that are critical, and and nobody knows the data.
It's a
Yeah.
male trait, Doc. You know that. It's a male trait. Men don't want to talk about it. They don't want to know about it. It's ask my wife. I have no idea. When I got diagnosed, I asked all kinds of old guys out at a softball league, and guys would ask me about it. I'd ask them if they, here, Bill, he's got prostate cancer. I say, hey, Bill, what was your Gleason score? What did you get treated? What did you know? Nothing. Oh, I don't
Right,
know. Ask my wife.
right.
Yeah. Very good point. One of one of my best friends from Napa Valley, I met in the men's changing room at UCSF doing radiation 8 or 9 years ago. I mean, we're still great friends to this day. He never comes on our calls. He doesn't do this, but we talk quite a bit, and I've helped educate him. And I mean, he wasn't totally dumb to these things, but he's learned over the years, and there's things that he probably should have known when he started, instead of being blind going into it. But yeah, the men's changing room is a great avenue. It's where we can, we can all, if we happen to find ourselves there, we can all be moderators. We've got a captive audience. It's a good point. I always wonder, here we are, 28, 27, 28 of us, a small percentage of the number of guys that are diagnosed every day, every week, every month in this country. Um, Very few people willing to be their own best advocate, or even their own advocate at all, even if it's not their best advocate. Very few people will speak up, and we need to reach them. I mean, we've got a big task ahead of us. A couple of people want to make comments on that. Vic again and Jeff.
Yeah, I was wanting to ask Alan, uh, what what was the name of that clamp, and if you don't mind sharing, where do you get it? Where did you buy it from?
So it's Lunderg, Lundberg, I think, and I got it off Amazon.
Oh, okay. Thank you.
Yeah, yeah, and I eventually used it for longer car trips because I got tired of peeing in the portable urinal. So I'd throw it on for an hour and a half when we drove down to Philly.
Where do you put the clamp? On the tip of your penis?
Midway down the penis.
Midway
And
down.
no pain, no really pain at all. And they have different sizes. You get it with 3 different sizes, small, medium, and large. And then you clamp it down to different tightness. So there's a thing where if you need to clamp it down tight, like if I went in for radiation, I did not want to be peeing on that table, and I did once, and that was really lousy. So I might clamp it down a little bit harder, but for a car trip, not so much. It was not uncomfortable at all. I couldn't leave it on forever, of course. I think they said 2 hours max.
Very good. And Jeff Marchi, you had a question or comment?
Yeah, by the way, Kaiser has this special urologist who does all of the different treatments for people who have incontinence. And she recommended the Wiesner clamp, which also has 3 different sizes. And I've used it when I go dancing, for example, and don't want to have to worry about leaking more than usual. But one thing really puzzles me here. Dr. Jeff mentioned having to drink 40 ounces of water. And I had my radiation 35 plus treatments 10 years ago. And I was required to drink 16 ounces of water. I got in there. I'd usually get in there and have my treatment within 20 minutes of when I left home. So about like 45 minutes from the time I left home, I'd have the treatment. Nobody ever mentioned having incontinence issues. Nobody ever mentioned having to drink that much water. Have things
20,
changed that much?
20 ounces.
Oh, okay. 16 is what I had to drink. And of course, I had absolutely no incontinence problems back then. So it's maybe a different issue, but no, I don't remember anybody. Well, I guess it's because
They
were
had me
running
drink
through
40.
people so quickly.
Yeah, you need a full bladder and empty bowels. That's what they did. And then they took a picture of me, and sometimes they said, "Yeah, your bladder's not full enough. Go drink some more water."
Yeah, I didn't have that issue. It's interesting. But I always drank the amount of water they said, and that's all I gotta say.
Yeah, and by the way, the Wiesner clamp and the Lunderg clamp, they're essentially the same thing. I mean, they look very similar.
Okay.
Rick, didn't you say, Rick, that you didn't have any such requirements when you had your radiation?
Yeah, I mean, it wasn't even mentioned. That never even came up.
That's interesting.
Yeah.
Same with
Because
me.
they were telling me.
I had 19
it's
radiation
possible.
treatments.
It's possible because my external radiation was across the pelvic girdle, because I had seeds to the prostate gland. So maybe that was why, because they were radiating the pelvic girdle as opposed to the gland. I don't know. I'm just guessing. That's the only thing I can think of.
Yeah, mine was to the pelvic girdle because I didn't have a prostate at that time.
Oh, that's right. And they made you do it. Yeah. I don't know.
Interesting. One of the selling points of the Meridian ViewRay radiation machine was that with real-time MRI tracking, they don't seem to have to worry about this, because every time the bladder interfered with things and the target moved, shut down. So they didn't have to worry about stray radiation or getting that out of the field. But they have financial problems, so it's not being pushed right now. But it was one of their selling points. Okay, well, this is an excellent conversation. Jerry, you have the last comment here. Jerry Grimes.
Thank you. Briefly, I had 44 sessions of radiation as my primary therapy. I made sure I was well hydrated. I stopped drinking all fluids 2 hours before the appointment. 30 minutes before and that let my system normalize. 30 minutes before the appointment, I would drink a specific volume that I experimented with during the month before my radiation series. It turned out to be about 13 ounces. And I would drink that during the half-hour trip to the hospital. And once I got to the appointment, I had just the right amount, and it would hold there for a long time because I had a baseline level of hydration. So just a thought. No special things required. I never did have a big problem. But to set a baseline, stop drinking all fluids 2 hours before the appointment. One other quick comment: peeing on the table, no big deal. The technician said don't worry about it. If it does happen, it happens all the time. They just clean it up. You go drink some more water and come back. It's not a big deal. It's embarrassing to us, but they just don't care.
You had
Not my
radiation.
experience.
You had radiation as your primary treatment. You didn't have a prostatectomy, Jerry, right?
Correct.
Okay, big difference, When you have a
Yeah.
prostatectomy, the sphincter is so iffy.
Okay, good discussion. Excellent points. Thanks, Jeff, for bringing these things up. Vic, you have something else you want to bring up, an update?
Yeah, update for myself. About 2 years after I started triplet therapy, I got a pelvic scan for a orthopedic pain situation, and it revealed that my lesions had pretty much disappeared. Had my oncologist look at it, and he said, "Yeah," he says, "from the surface down inside to the marrow, it looks like normal bone." So I got my next PSA test after that. It was 0.02. No excitement. That's noise, I'm guessing. 6 weeks after that, 0.03. Another 6 weeks, it was 0.02 again. Still thinking noise. And then it went to 0.08. And the last one was 0.17. So this is when I hop to message my oncologist and say, I think I'm a Provenge candidate right now. And listening to last week's meeting, I think it was last week's meeting, Jeff brought up issues about whether or not to quit your Abby and prednisone while you're on Provenge. And I started doing some research on that and shared a link to a study that I found related to that. So interesting, my oncologist said to me, "I'll let you decide if you want to quit your Abby or not." He really didn't have a strong opinion either way on it, but he was obviously aware that there's kind of competing information out there regarding whether or not to stop the Abby. So that's my next treatment I'm heading to. I've entered the castration-resistant phase now, and so going to do the Provenge first, then probably be looking towards most likely Enza, I'm guessing, as my once he says he wants to stretch out the Abby as long as possible and maximize the benefit from it. I'm going to talk to him about maybe possibly switching from prednisone to dexamethasone on that, and that's kind of where I'm looking at. But I'll get through this Provenge treatment and then be talking with him more about what may follow with that on that.
Very good.
So I just put in the chat window the study that Vic referenced, and it's good sleuthing there, Vic. And I'm assuming that you're not going to stop your Abby whilst you're doing the Provenge. You're muted.
Vic, you're muted.
Sorry about that. Yeah, I'm gonna stick with the Abby, I think, based upon what I read from that study.
Mm-hmm. And we've had a lot of guys who have done Provenge. As you get closer and you're scheduled, you can bring it up. You can get references. The big issue with the Provenge, I forget when. I think it's when they are taking it out. Is you have to, when they're taking your blood, you have to stay well hydrated. and some of the guys have sort of blacked out and had some issues, and then they've had to stop and then give them an infusion, a saline infusion, and then restart it about 40 minutes later. But and we haven't heard that more recently, so they may have improved the protocol. Early on, it was a little more common, but that's basically the only issues. And there's the only thing is it takes a long time, and you can't move around very much, so it's good to take stuff in to watch or read or do something.
Yeah, right now my biggest concern is how am I going to scratch my nose when it itches?
Right. But I'm sure if you ask the guys who have done it in this forum, they'll tell you how to scratch your nose. Somebody's got that. Oh, Jeff Betts has got his hand up. Jeff, did you do Provenge?
No, I wanted to ask, what are you talking about?
Who would like to explain it? Me, you, Peter?
We can both do it. Provenge has been around a long time. It's the only, for a long time, was the only approved immunotherapy for prostate cancer. There are now some other, well, probably it still is the only approved immunotherapy for prostate cancer, I believe. There are some other immunotherapies if you have meet certain criteria in your genetics and so forth, but Provenge is the only one. It was developed by one of the docs in San Francisco at UCSF, Larry Fong, and a number of years ago it was bought out by a Chinese company. I'm assuming it's still owned by some Chinese outfit, but it's a little bit involved. You've got to have your blood drawn, as Rick was just intimating, a couple of days before it's infused back, and there's two labs, one on the East Coast and one on the West Coast, where they send the blood right away by express, and they I can't describe the whole process, but they pull out of the blood certain components and infuse it with this immunotherapy agent, and then it goes back to you, and 3 days later, or whatever it is, you get it in your blood infused back into your system. It's not a promised thing. It was approved because it seemed to show that overall survival was increased by several months, but there's a lot of unknowns about it. Like, is it better to take it early on? That's what the seeming thought. That's what the prevalent thought is. Rather than as a last resort, you're better off taking it early on in your disease trip, rather than trying it as a last resort, because you might get more bang for the buck. But it's a hard one to definitively say Provenge actually extended my life 10 months or 8 months or something like that.
Well, I'm not sure how hard it is now, because there are studies that do show that it improves overall survival. The problem is the studies are somewhat questionable. I mean, the way that it works is that it surrounds the tumor. So it stops the tumor from expanding, but it doesn't stop it from growing. So you don't necessarily see a reduction in your PSA, but the tumor can't spread as quickly. And what we know is the longer the runway when you get it, the more likely it's going to have an impact. Now, there's a lot of doctors that don't subscribe to it because they say, well, we don't see the results. But they don't see the results because, in our view, they haven't studied the results. Larry Fong is on our advisory board. He's an outstanding he's a wonderful individual and an outstanding doc. He's at UCSF, and we'd be happy to, if you've got a doc who says I don't see the value, we'd be happy to pair him up with Larry, and they can talk to him. But we tend to suggest that if you are already castrate resistant and you haven't had Provenge, and you're eligible, to get it as early as you can in the process.
As Vic was intimating, you're supposed to show 3 consecutive rises in your PSA indicating castrate resistance. There are some ways around that. People were getting rid of their ADT. Anyway, but that's part of the criteria for it.
Yeah, on-label use of it is less than 50 on the testosterone as well. So if your testosterone's above 50, it's not an on-label, use of it. But I imagine there's some docs that work around that. And I said that my biggest fear was how to scratch my nose, but one that just left was we're doing this from the first week of December through the first week of January. And here in the middle of the Midwest, weather, and who knows what it will do with the air traffic. But my fear, almost as much as the weather, was a government shutdown, which I just found out I don't have to worry about for that period of time. So I'm happy to know about that. I had one more thing real quick. Since it was just turning castrate resistant, also had blood drawn for somatic testing. So I'm going to get that taken care of.
Good.
And my metastasis, as far as I know, at this stage are bone only, but we'll be talking about, probably PET scans at some point as well, just to make sure we haven't moved out into the soft tissue range. So yeah, that's where we're heading.
Good. Thanks, Vic. Wish you well. Let us know how it goes once you start it.
Definitely. Thank you, guys.
Yeah, and you bring up a good point. I know where I live, I can't do it here on Maui. I'd have to fly to Honolulu twice a week, every, whatever it is, every 6 weeks, something like that, to do it, because the dependability of air traffic, not only weather related, but just how many flights and getting to the West Coast or East Coast on time and getting it back, and having a center where you can get your blood taken out, the Red Cross or whatever. There's a little bit of humbug involved in this. It's not like just going to the hospital and getting an infusion. It's a little bit more involved. Okay.
Len, did you want to add anything about the Provenge?
Well, did we mention that the lower your PSA, the better, like less than 4?
Yeah.
And what was your PSA, Vic, when you started?
Last reading was 0.17.
Oh, you're in a sweet spot there.
Yeah, he's just starting.
Yeah, I'm about 2 weeks out from my first collection and infusion, or first week in December, so maybe 3 weeks out.
And Jeff Betts, what they do is they take out your blood and then they send it away, and 2 days later they infuse it. They infuse the plasma back in, and they basically have inoculated it with dendritic cells, which are a type of immune cell.
Anyway, with all the talk of immune therapy, there's still some yardage to make with prostate cancer. There's not many new things that I know of. Maybe there are things in labs that we don't know of, or maybe some of you know about things popping, but there has not been much talk about immunotherapy and prostate cancer in recent days that I'm aware of anyway. But hopefully there'll be more. Okay, Todd, you said you had something you want to bring up tonight.
Yes, hi Al, how are you? Thanks for letting me have a little bit of time. As an update for everybody, since I haven't been on for a bit, I started on ADT back in April and had metastasis up into my abdomen at that time with the PSMA. And then about a month ago, I had another PSMA in Chicago, University of Chicago, and it showed nothing. So, ADT has now been 7 months, and I'm also working with MD Anderson. I had a bad experience at University of Chicago when I did my scan last month or about a month and a half ago, and the blood and urine, and had a bad experience, 3 different things that same day. So I'm switching over to MD Anderson, and Dr. Hahn and Dr. Mayo at MD Anderson, who I also met with back in April, have kind of concurred or agreed that even after only 7 months of being on ADT, that I can do a holiday. Like I said, I had a dark scan about a month and a half ago at University of Chicago, and so that's what I'm looking forward to right now, is to do a holiday, a drug holiday.
And you only started ADT in April.
It's 7 months. 7 months right now, yeah.
Okay.
Excuse me. Where did you have metastasis? You said to your abdomen.
Yeah, so I've had lymph nodes in my up into my abdomen, but very small, and obviously down in my pelvis. No bone.
No viscera. No viscera. You say abdomen. I didn't understand. What you were talking about. Nothing in the liver. Nothing in just your pelvic area.
No, up into my abdomen, but very, very small. But that's all dark now with this last scan.
Yeah.
When you say
I'd be really concerned, Todd, if it were me. Essentially, you were diagnosed. Well, hold on a second. Let me just correct myself. You should have been on our call last night, Todd. I'm just digressing for a second because there was a guy who almost got sucked in by Scionti, and we told him that we have too many guys around who didn't do too well by Scionti, and I think he's not going to go there. So here's my concern. They're basing, because you're recurrent and because you had recurrent disease, they're basing their advice to you on 6 months of ADT on a study that I think was done a couple of years ago. But there's a newer study out now that shows that really 18 months is the right period to be on. It shows better results. I can't lay my fingers on it. Len may be able to find out, but it's something that's come out pretty recently. And if it were me personally, I would get a second opinion before going off after 6 months, especially in your situation where you're only partially. It's not like regular recurrent because you only got focal in the first place. And if you're willing to go to Houston, go across the street or go next door and go ask Dr. E what she would do.
Well, I'm meeting with Dr. Guanchel next week.
Perfect.
As you may remember, I
yes.
kind of had a triad of University of Chicago. And,
yes.
I'm totally turned off by them right now. And so I'm meeting with Dr. Guanchel next week to talk about this further. But I spoke with Today, actually, coincidentally, I spoke with Dr. Hahn, who's very sharp at MD, and he is very comfortable watching my PSA as long as my PSA is below 0.1 with this next one that we're going to do. Watching the PSA going forward every month and a half, and as long as the PSA stays down, being on the holiday. So as you probably know, Rick, I'm sure you know this, that because of what the industry is used to doing, they've never really tried being on holiday after such a short amount of time. Usually it used to be 3 years, and now it's more like a year and a half, I guess, is kind of the standard for, trying on holiday.
Not really, because what they've been recommending recently when you have recurrent disease is that you do radiation and 6 months of hormone therapy, and that's pretty much been the protocol for the last couple of years. The concern is that maybe that isn't long enough, and so that's why. But Dr. Guanciale is terrific. And be sure to ask her about the most recent study that's come out as to how much should accompany recurrent disease. But the issue with you is you're not straight recurrent disease. So you're somewhere in between recurrent disease and de novo metastatic, because the focal that you got in the first place was never a complete treatment.
Right.
Do you follow what I'm saying?
Right, because of the HIFU.
Yeah, because of the HIFU. So for example, if you would have had a complete ablation in the first place and your disease had come back, they would have said, okay, and they were able to treat it when it came back with radiation. They would have done the radiation and they would have said to you, do 6 months. Yeah. And we always said 6 months isn't enough, but the study showed 6 months.
Yeah.
So it isn't really a holiday. That's the protocol. Like if you had surgery, you'd had surgery or some complete ablation in the first place. That's where I believe that's where the 6 months is coming from. The question in a case like yours is this really recurrent? And if it isn't, how long would you put a man like you on in the first place? And so that's why I would be looking to get a second opinion. And I think seeing Dr. Guanciale is an excellent opportunity for you. But be sure to raise with her the new study that just came out in the last month or so, showing that 6 months is not the optimal for recurrent disease. But she may, but I just want you to talk it out with them, and I'll make a note and I'll try and look later and see if I can find that study. I saved it, but I don't want to look for it now because it's going to take too long. But I'm writing a note to myself right now.
Okay.
And I'll try and find it so you can do it. But she's great. Len, what do you? Where's my fratello?
Yeah, I'm partial to what you're saying, Rick. I think that makes sense. And at the same time, I would tell Todd to put a lot of faith in whatever Dr. Guanciale, however you pronounce it, tells you. I think she would have very good judgment on this.
Right. I mean, let me just say one. Let me just say one thing, Peter. I just want to reiterate. I personally would put more faith in Dr. Guanciale than your doc at MD Anderson. If it were me, I would put more weight. I would put more weight on Dr. Guanciale because we know her heritage. We know where she's come from. I don't know Dr. Hahn. He's maybe one of the newer GU medical oncologists. If it was Dr. Korn that was saying this to you, I'd say fine. I'd still say maybe get a second opinion, but we don't know Dr. Hahn. We may get to know him, but we don't know him now. We do know Dr. Guanciale. She's got a great pedigree. She trained under Dr. O. and I've actually met her, and she's lovely, and she's a great dog. As
Okay.
you know,
Well,
sorry, Peter.
I'll look forward to that meeting with her. The other thing, and I brought this up before, and I know it's controversial, but the fenbendazole, which I've been on for 6 months, I'm just curious if any of you have had experience with that or thoughts on that.
What is the drug?
Fenbendazole.
Is it a proton pump inhibitor? Is it?
It's actually a it's a drug that's
Dewormer, isn't it?
and animals for deworming. It's a deworming drug
Yeah.
for animals. It's FDA approved for animals, and it's something that has been used, around the world for folks with cancer after they gave up on everything else, and it's proven to be very effective to kill cancer. It's not FDA approved. Big Pharma is never going to approach it in terms of a real drug because it's almost free. There's no benefit to them. But we have two personal relationships with people that were told to go home and pack their things, and they were going to die within 2 months. And they went on it, and literally 6 years in one case and 8 years in another, they're still cancer free. And these are people that we know. So it's very real, at least in their lives, it's very real. And as a result, I certainly believe in it. And so there's no side effects. It's almost free. And so one of the reasons I decided to go off of the ADT is because I'm anxious to see if, in fact, the fenbendazole will, take me to where I want to get to.
Can you put the name of it in the chat window in case anybody wants to look it up? I don't think we should have a discussion about it but if people want to look it up, I'd be interested in looking it up too.
Peter, there actually is a prescription drug. I'm not going to pronounce it right, but it's menbenzanol.
Yes.
And it's supposed to be the same thing, only it's prescription.
Yeah, it's a similar drug. I don't know the differences. They're similar, but yes, I've heard of menbendazole. Yes, but fenbendazole is the one that I'm talking about.
Okay, if you can put them in the chat window, in case people want to look it up. So,
yeah.
Todd, I have a question for you. I want to go back to this abdominal Mets thing. This is not a common place for Mets, and I bring this up because that's where mine are. I've had them for a number of years there. Is it like in your peritoneal cavity, or I mean, we're not looking at lymph nodes. We're looking at Mets within the abdominal cavity. Yeah.
Yes.
Yeah, and it was picked up on a PSMA scan?
Correct.
Yeah, that's how mine were too. And mine was ambiguous when it was first picked up because it was an early PSMA scan on trial. They weren't absolutely sure it was prostate cancer, so I had to have a biopsy of it, and sure enough, it was prostate cancer. I did 6 months of chemo and a scan after that, and the Mets were still there. So, and you say yours have gone away. So, it's an unusual place. It's common. It's much more common for women with ovarian cancer. They even do flushes with liquid chemo to hit that cavity for women. But it's not. There's not many I've run into that have abdominal Mets. So. I'm just curious, a little more curious about it because you're the first person I've heard with a similar situation as I've had.
Yeah,
and
they're very small. They said they're very small, almost not non-detectable, but very very small, and so yeah, they're definitely in the abdomen.
Yeah, mine they referred to them as implants. Yeah, it's not as lymph nodes. It's very interesting.
Yeah.
Has your cancer been sequenced, Todd?
It has, but I can't tell you what the results were. That was back back at the University of Chicago back in April.
Okay.
I would get the results if I was you.
Yeah.
Yeah. I think you need to get a copy of the whoever did the sequencing. Do you remember which company it was? Was it Caris or Foundation Medicine or?
I don't, Rick, but I will definitely look into it.
Yeah, get yourself a copy and let's take a look. And Len, I just want to ask you if you have anything to say on fenbendazole.
Well, all I can say is it's never been put in clinical trials for prostate cancer for men, as far as I'm aware. They've done preclinical studies in mice, and it has been shown there to have anti-cancer activities. I think it's a microtubule disruptor, which is similar to the way docetaxel works. So in other words, it prevents cells from successfully dividing. What can I say? There's no clinical evidence that it works, but on the other hand, there is preclinical evidence, and it's kind of hard to argue with Todd's friend's experience, I guess. I certainly want you to talk to Dr. Guanciale about that, Todd, get her opinion.
Yeah. Well, I did when with the University of Chicago, but when I did talk to, Russell Schmolwitz about it, and he said, I'm fine with you taking it, but I want to make sure that it's not going to be a problem with your, ADT drugs and whatnot. So they did check that out. There was no issue there. And there are no side effects per se. If there's any side effects, they're very minimal. And the reason that there'll never be clinical trials, and actually Dr. Hahn and I were actually literally laughed about this afternoon, is that if you have a drug that actually can cure a problem like cancer and it doesn't cost anything, and there's no opportunity for big pharma and the rest of the industry to do something with it, there's no way in hell that they're going to, do clinical trials or anything else with it. They're going to ignore it and hope it goes away.
No, that's not true, Todd. And Dr. Hahn knows this too. That's exactly why the NCI and the NIH exist. It is the very reason for the NIH and the NCI to exist, because they will pick up on drugs that don't have a commercial potential, and they'll run the trials out of the NCI. So, I don't buy that argument. There's got to be other reasons. And if somebody really thinks it works, they can put together a trial and they can send a proposal to the NCI. They have the budget to follow it through.
Yeah.
Todd, can I ask a question, Rick, or do you want his answer?
Neil
hold on a minute.
Neil has a question first.
Okay.
Yeah, Neil has a question for you.
Yeah, thanks. I didn't really have a question, but you were talking about the duration of the drugs you're taking. So I'm taking Orgovix, and I've been told my doctor was a little bit, hesitant about giving me a date of how long I'd be taking it, but I've been on it 7 or 8 months now, and I think that the full schedule is 46 weeks with the Orgovix. That's what I was told by the PA. So we'll see when I get to that if they want to prolong it or not. But 46 weeks, not 6 months, not 18 months, is kind of in between. But that's just what I understand.
Okay, quick, Jerry, go ahead.
Todd, I just want to know what type and what company you're buying it from.
So, if you Google it, which you may, you'll see that when you go to any, you'll see that it's controversial. Obviously, there's anything to do with the healthcare industry. You're going to see where they say, well, this doesn't have trials, so it's nothing. It's not worth pursuing. But then if you can find your way to where there's actual testimony about people that have used it, there's been some incredible results. So
that's not what I meant, Todd. I know that. Health Unlocked is another prostate cancer site that you can go to, and there's been a lot of discussion about this there. But what I wanted to know was they're talking about, God, I think it's Panicare-C, which is actually the dewormer for the dogs.
Right.
And other people are actually going to, I don't know what company, but they're actually getting the fenbendazole in a bottle with a pill.
So it's called Fenben, and you're right. It's called FENBEN, and it's a company that has taken it and put it into pill form, which is what I take. And it's Fenben, FENBEN. If you Google that.
Okay, but the milligrams is 449 as opposed to the 229 that they were promoting earlier.
Yeah, so there's been changes in the protocol. One thing that has been said, and what do I know, but these doses of 229 or 400 and whatever are 1/100th of what they give to animals. So it's very, very low dosage. It's very safe, supposedly. There's no side effects. I've had no side effects, so I've been on it for 7 months now.
Yeah, okay. Thank you, Todd.
Thanks, Todd. I'm gonna cut it off. I don't want to prolong the conversation about this. I want people, if they're interested, you got the name in the chat window. Do your own research. I'd be interested to see what Dr. Myriad or Dr. Schultz, I'm sure they've run across this discussion. Yeah, I'll look into it too, but I don't think this is the right forum to go on too far with it.
Sure.
But
Sure.
Thanks for bringing it up, though, for sure.
Thank you for your time.
Yeah. Dennis, you're up.
I didn't need any time, Peter.
Oh, I thought you said you did. Okay.
No, thank you.
Okay. That opens the door for Chuck.
Hi, guys. Yeah, so just to give you an update, I completed my first round of Pluvicto about a week ago, last Wednesday, and everything seems to be going smoothly, except I have no side effects or anything. But my main question is concerning lymphedema. I was on chemo for 10 rounds. I finished up last July, and on around the eighth round, my left leg started to swell up, and I had previously had a big blood clot in my leg that went from my thigh to my calf, which I'm on blood thinners for. But after the eighth round of chemo, my leg started swelling up, So I went to a lymphedema at NYU where I'm being treated, and they recommended I go for physical therapy. So I have an appointment next week for they're supposedly going to do massage or whatever to help stimulate the other lymph nodes to take over some of the burden for the ones that are cancerous, because I have cancer in my abdominal lymph nodes. So that's probably, she thinks, the lymphedema doctor thinks that's probably why I'm getting this lymphedema swelling. So I just wanted to ask if anybody had any experience with lymphedema, in their legs, or due to cancer in the lymph nodes, and what you did about it.
I went through it when I did chemo. I never associated it with my lymph node mets. I mean, I just mentioned to Todd that I have an abdominal implants there that are cancerous. But I never put the two together. But I did have, toward the end of my chemo treatment, I did get swelling, but it did go away at the end. It
Okay.
did not. Yeah.
Okay. Yeah, because I finished the chemo July 6th. So it's been July, August, September. It's been like almost 5 months now. So by then, I think it probably, the swelling would have gone down, but I did have it in my right leg somewhat, but the one in the right leg actually disappeared, the swelling. But this left leg, I wake up in the morning, it's okay, a little swollen, but by the end of the day, my leg is just really swollen. So
You've got the compression socks?
yeah, I do wear those. Yeah, they do help, but my, it goes all the way up to my thigh. My thigh is, rock hard, but anyway, I was just curious if anybody else had this similar problem.
And
So,
you want a good physical therapist, a physical therapist who's experienced with this stuff, not just any front-of-the-mill one. Yeah.
Yeah, and I'm going to Kessler, so they're pretty good. So I'll see what they say. Hopefully, but another thing I'm concerned about, maybe it's due to the big blood clot that I had in my leg. But I recently had an ultrasound, and it didn't. They said that the veins weren't blocked. There was just residual scar tissue from the clot that was it was pretty bad when I first got it, but it's pretty much cleared up, except there's scar tissue in so that may be contributing to the problem. I don't know.
did they make any comments to you about the valves in your veins and how well your valves are closing? How quickly they're closing?
She did mention that, yes. In fact, my father has that problem. He's got horrible problems, lymphedema in his leg, or not lymphedema, swelling in his legs due to the valves not working properly. So it could just be hereditary, too. It could be a valve problem. I don't know.
Because there
But
is a
anyway.
special ultrasound you can get on your legs that measures how long it takes your valves to close, and if it's a prolonged closure, that's why you get the fluid collection, because the valves are just taking too long to shut.
Okay.
And it's not
All right.
related to cancer or anything like that. And it usually responds pretty well to leg elevation and compression stockings. And I mean, sometimes surgery is utilized if conservative measures don't work.
Okay. That's a good thought. Thank you. So I'll have to look into that. So there's a special CT scan I can get to check the valves. Okay.
It's an ultrasound.
Oh, it's an
You
ultrasound. Okay.
don't even need a CT. It's a special ultrasound that measures the speed with which your valves close.
Okay. If that,
Vic,
yeah,
Vic,
I'll.
Vic, you had your hand up. Did you have something that, oh, you didn't? Okay. Okay. I thought maybe you'd had some experience. No one else here had experience with swelling of their lower limbs or their arms as a result of treatment. We have seen it. I mean, one thing that and I just read an article on it. I think it might have been in the last Cancer Today. I got to go and look later, dig it out of the garbage can and see if I can find it. But sometimes acupuncture can be helpful. So if you're going to get some massage, ask the masseur whoever's doing the massage, if acupuncture would help release it. I mean, we've read that it's definitely helpful, and these are issues that women face a lot as a result of breast cancer. Not so much in their legs, I think in their arms, the lymphedema in their arms. But if you're getting the treatment at NYU under Dr. Weiss, I mean, he should be sending you to the right people who know a lot about lymphedema.
Yeah, I am actually getting acupuncture once a week, so I read that it does help. But yeah, I am seeing the specialist lymphedemist or lymphedema doctor at NYU. So
okay, well, yeah,
we'll see what
that's
happens.
good. Unfortunately, Dr. John isn't on tonight because he actually practices acupuncture, and it would have been interesting to hear what he had to say about whether he's ever treated anybody for lymphedema or not. But I'll find out from him when I next talk to him. I'll ask him. Okay.
Thank you. Thank you. Thank you.
Yeah, I know what you're going through. I know what you're going through. It's pretty annoying and can be concerning too, particularly if you've had clots. It's it's not fun. Yeah.
No. Yeah. But thank you. Thank you, everybody. Thank you.
Chuck, one quick question. When you got this thromboembolic situation in your leg, had you had a COVID vaccine anywhere near that event?
Trying to remember. I think I got let's see. 2020 was when I got the blood clot. So about 3 years ago. I'm not sure. I can't remember if COVID was going on then. I think it was before COVID.
Before, okay.
Yeah. But have you heard that could cause?
Yes.
Really? Okay.
A lot of reports on COVID vaccines and blood clots.
Yeah, but the COVID vaccine didn't come out until 2021.
Well, that's why I'm asking him for the timing.
Yeah.
Yeah. But yeah, like I said, my father has horrible blood clots, and my grandfather had them, so it could all be caused by the blood clot. Who knows? But anyway, thank you. Appreciate your help.
Thanks, Chuck. Okay. Back to Alan.
Yeah, so just real quick, I had another PSA and it came out undetectable. So I've got 3 in a row, which is very good. Just sitting back and watching. That's all. Less than 30 seconds.
Good for you.
I don't know what that means, because I keep telling Dr. Gainesman, yeah, well, but we do know it's going to come back, right? And he said, well, we can't be sure. Okay. But hey, I'll take it.
What treatment are you on?
I'm not on any treatment at all. I just finished up the end of last year with Orgovix and radiation. And after that, it was undetectable, and so far, so good. And I was on the Orgovix only for 6 months.
Right.
But I also know that he's concerned because he's checking me every 3 months. So he's not like, yeah, we can, string this out for 6 months. No, he wants PSA every 3 months.
Well, good.
What was your Gleason score, Alan?
8, 4 plus 4. Yeah.
Okay.
So I was scared. I mean, Rick will tell you, man. When I had recurrence, man, I was a basket case. I really was. And then I looked, I did the research on the Gleason score of 8, and it was like, yeah, this is an aggressive cancer, and I'm in big trouble. But doesn't always pan out the way you think it will.
Right. You're doing well.
Yeah.
You're doing well.
Life is treating me well. So far.
Can I just go back to Chuck for a second? And Chuck, I just want to make sure that when you see the lymphedema doc, you mention to her that you do have this family issue with the valves in your legs, if you haven't mentioned it to her already.
Yes, as a matter of fact, I did tell her that. Yes, so
Okay.
she's aware of that. But she thought that it most likely is due to the cancer. So yeah,
Okay. Okay.
thank you.
And Neil, I think Neil has his hand up, Peter.
Yes, I
Yeah,
see that.
yeah. I just had a question for Alan. Alan, you said you've had 3 non-detectable. Is that 9 months worth?
Yeah.
So
I
3,
didn't count the
and
one
you're
right
getting
after I finished the treatment because, well, what's it going to show? But
right. Okay. So that's 9 months. That's great. Congratulations.
yeah,
Good
thank you.
report.
Right. Are they going to keep you on the keep you on the 3-month cycle, or are they going to move to 6 months?
No, he said he's going to keep me on the 3-month cycle, which means, okay, he's not seeing me as out of the woods. He didn't say that, but I can read between
Good.
the lines. Yeah,
Good.
that's fine with me.
Yeah.
Oh, and my testosterone was within normal limits too. That's the other good piece of information, I think. I'm happy with that.
Well, we're happy for you.
Thank you. That's it.
Okay, Spencer.
Hi. I just I had was diagnosed a year ago. I guess last October of 22, and I've been on the anti-androgen therapy with abiraterone and what's the injection Lupron every 3 months, and the abiraterone every day. And initially, I had pretty good success with it. My PSA went from like 22 down to around 2, but now the PSA has gone back up again. It's now around 7, and they switched me from the abiraterone to darolutamide. So I'm now taking darolutamide, and I have another. My next appointment with the oncologist is in December. But on top of that, I've been having a lot of rectal pain from the from the tumor pushing up against my rectum, and they recommended I do a course of radiation to alleviate that. So I had the radiation. I just finished it last week, and as of right now, I'm in more pain than I was when I started. So, but they said it would take a few weeks for it to really kick in, which I hope they're right. I do have a question about the. We had that whole discussion before about the getting enough, filling the bladder. They with water, with urine before taking it. They told me to do it, but they never really made a big deal about it. It wasn't like I had to drink a lot of water before that or anything, and they never really asked me about it. They never checked it. But what I did is I would drink water, but never never to the point where I was uncomfortable, where I felt like I couldn't stop myself from going. Um, and I hope that's okay. I mean, I went through it. I don't know what are the effects if you don't have enough water, enough urine in the bladder, and you have the radiation. Does it do bad
So
things to you?
what I was told is then you put yourself at risk for damage from the radiation, to your bowels, to your rectum, to other body parts. They told me I had to do that to protect it. And they did I don't know what, like an ultrasound, or they did some sort of x-ray. Even before we started, he would say, your bladder is only 70% full. It's got to be at least 90% full. We're not doing your radiation. Go back to the waiting room and drink more water.
No, they never did. They never did any of that.
Wow. That just shows you the differences, man. They made a big deal about that.
Huh. I hope it's all right. I don't know.
Spencer, are you taking anything for your pain? Is it that kind of pain?
Yeah, I'm just taking what do you call it? Just a mild painkiller. I forget the name of it. But it's like the lowest level
Codeine.
codeine.
Percocet.
Okay, because
No, yeah, like a no, it's even less than Percocet.
opioid painkillers can cause constipation,
Yeah,
which if you've got rectal issues, that could.
yeah, I know. I've been doing
Spencer,
that. I take a stool softener too, and the rectal thing, the constipation has been a problem, and even when I do it normally, it causes pain after just moving my bowels causes pain, which lasts for a couple of hours. But I'm hoping that the radiation, whatever happens with the radiation, will kick in and shrink the tumors enough where I won't have any pain.
how many treatments did you have, Spencer? Radiation?
16.
16? Is it SBRT or IMRT? What do you do?
IMRT.
Okay.
Yeah.
So, a couple of things that come to my mind, Spencer, that I would suggest you run past your docs, okay?
Mm-hmm.
One is that you also might be a very good candidate for Provenge right now.
Oh, okay.
And again, you might get pushback, but if you get pushback, you have to be more insistent. A lot of these docs say, well, we don't see it does any good. But we feel that you might not see it, but people live longer when they get the Provenge and when they get it early, and you don't want to wait too long to get it. So
Okay.
definitely discuss the Provenge. The other thing is, do you have a palliative care doc on your team?
No.
You've got to get a palliative care doc on your team. Palliative care is not hospice. It's not end of life.
Right.
They are the docs who help you deal with these side effects. And
okay.
and again, if you get any pushback, come back and talk to us here. If you've been reading the reminders, the NCCN guidance is for any person with cancer to include a palliative care doc on their team. But there are some doctors, some oncologists who don't like to involve palliative care because they feel they lose control. We disagree with that strongly, and we navigate our folks to include a palliative care doc on their team. And then you can be working with them about the pain that you're having, other issues, the constipation issues, but that's why you have. So Jefferson is going to have a palliative care service,
Sure.
and you have to insist that you want a palliative care health professional on your team.
Okay.
Well, I don't have a name. I don't have a name to give you at Jefferson, but so that's two items to take away. One is to discuss Provenge, and the other is to discuss adding a symptom management doc or a palliative care doc, or what I like to call them a quality of life doc.
Quality of life. Okay. Palliative care. Yeah. Well, I mean, Dr. Tester recommended the radiation as a palliative measure, not as a not as a treatment. But although it is a little bit of a treatment, I mean they said that they would try to get as many target as much of the tumors as they could, and it would help. But so far we don't know. But yeah, in terms of palliative care, just have somebody that would just address the symptoms that I'm having. That sounds like a great idea.
That's what they do. That's their job.
Okay.
So you insist on it, and if you get pushback, you can. I think it was in this week's reminder. No, or the week before, the week before's reminder. I put a reference in for the NCC guidelines on palliative care and
Hmm.
quoted something. So dig that out, or write to me, and let's get you a palliative care doc.
Okay. Definitely will follow up on that. I appreciate it.
Yeah,
Thank you.
yeah, very important,
Yeah.
particularly in your situation. Yeah, for sure.
Okay.
And so did the radiation mitigate the rectal pain you had?
No, it's right now. It's
Yeah,
worse.
worse. Yeah, that's
Yeah.
what I was wondering because, generally they try to protect the rectum from radiation.
Yeah.
What did they ever discuss chemotherapy with you?
Yeah, he's discussed it, but he doesn't think I'm a great candidate for it. He thinks I'm too old, or that I couldn't tolerate it well enough.
Right.
I don't know, but
Well,
that's still not beyond the realm of possibility.
They do
again,
have a low dose protocol you could follow.
right.
Okay.
Yeah, there's a low dose protocol, and they could also, if they're nervous, they could also try you with cabazitaxel instead of docetaxel. So that there are options there, and for the issues you're facing, it may be worth discussing.
What did you say? What drug?
The Gemtesa,
Jeftana.
Jevtana, Gemtesa instead of Taxotere or docetaxel. And I'm working with a lower dose, as Len said. Those are the things we would suggest you discuss with your doc.
Okay, I will do that.
Okay.
Okay.
Vic, you had a question or a comment?
I was just going to echo what Rick said. I think there was a study came out of Finland, perhaps, that low dose docetaxel and cabazitaxel both, have been shown to be very effective with much milder side effects.
Okay.
Good. And Jeff Betts, you had something about the question?
Yeah,
Yeah.
I was just, we were talking about the radiation, and so did you guys get the aerogel and the gold markers when you had the radiation?
I didn't get the aerogel. I asked about it, and he said he didn't think it was indicated for the type of radiation I was getting. I don't know why.
Oh, okay, I know because they give it to me to avoid that problem, rectal problems.
Hmm.
Wow.
This is a little different, though, Jeff, in the sense that Spencer didn't have the radiation originally. The radiation he's getting now is to address pain from the rectum, possibly as a result of cancer.
Yeah, it's the pain is coming from the prostate cancer. Apparently, I have one very large tumor that's right at the end of it that's pushing up against the rectum, and the radiation was really to get rid of that or to lessen that.
Now, the radiation really helped me with my pain. It really made a big difference.
Did it kick in right away, or did you have to wait? Because
No, it was kind of after I got over it and started to recover, But yeah, it definitely made a difference.
okay, I'm hopeful. I mean, I'm hopeful. It's been about a week and a half since I finished.
Yeah, we're hoping that you'll turn a corner on it too. So
Okay. Yeah.
it'll make a difference because we can tell it's kind of miserable for you. Your body language is letting us know that this is not a good place to be.
No, certainly not. Certainly not.
Okay. Okay, well, hang in there, Spence.
Okay, thanks a lot. I appreciate it.
Kurt.
Let's see. My last PSA was on October 25th. And so that was undetectable PSA and nearly undetectable testosterone still. So testosterone of 3 for year total. So that is my last. Lupron was a 6-month injection toward end of January. So it should theoretically have started to wear off, but I've gotten an extra 3 months of free ADT, so yay. And test again in 3 months. So that's all.
Have any questions or concerns?
No.
Anybody have any comments about Kirk's report?
So you basically everything's status quo. Is that right, Kurt?
Yeah. I was hoping, I guess, that my testosterone would start to increase, but it hasn't yet. So that's then it. I'll give it. I won't really start raising alarm bells until a year out. So it's only been 3 months. So.
Right.
So
the thing with alarm bells is nobody's listening to them. If testosterone's coming up, there's not much they can do.
So sorry, just to clarify, your last ADT, when should it have worn off? Your last ADT?
Let's see, end of July.
Okay, so just to give you a comparison, I went 6 months before my testosterone started to show.
Mm-hmm.
And I was young at the time. I was under 60. I can't remember exactly how old I was. So it's not unusual. And then, it's also a function of how long you were on it. And were you were getting a shot. You weren't getting Orgovix, right?
Right. I was getting Lupron for 14 months total.
Right. So, be patient. It'll come back.
Yep. I am. I'm, like I said, I'm not raising any alarms yet. So.
Okay. That's the end of my list.
Oh, wow.
Four of you came on late. Jim Marshall, Julian, David Muslin, and Dave Gerber. Do any of you have something you want to bring up tonight? Because we have a little bit of time.
Negative on me, Jim Marshall.
Okay. Julian?
Nothing for me. Thank you.
Gosh, we're going to finish on the wire.
Peter, I have a comment I heard from a radiation oncologist consult I had that I'd like to pass on. Just his opinion, but he thinks that in the future, ADT will be no longer used as they develop more and more potent androgen receptor blockers, for whatever that's worth.
Was this? Can we ask? Was this your consult with the gentleman in Miami that Dr. Jack recommended and someone else, Dr. O recommended, or Guancial?
No, that's coming up Thursday.
Okay.
Pollock is Thursday. This was Guancial recommended this radiation oncologist in Sarasota. I really like the guy a lot. And he said he would like to refer me to Pollock because he trained under
That's
Pollock.
right.
Yeah, yeah. He said, I'm not really sure if, radiation would benefit you. I'd like to know what Alan Pollock's opinion is. So that's three people referring me, and Jack is four, I guess, referring me to Pollock.
Well, let us know.
Yeah, next week I'll let you know.
That shouldn't be any surprise. I mean, Lupron's been around so long that you'd think we'd get beyond it with modern technology now. But
did he give you the basis of his conclusion? Len?
Okay, Rick, you said you had some things you wanted to bring up.
Jack, what was it you were asking, Len?
I was asking Len, did he give you the basis of his conclusion? Why he felt that the Lupron, Orgovyx, and all of those will be phased out in favor of androgen receptor signal inhibitors?
I think it's just that he sees more and more often that people are using androgen receptor blockers as monotherapy, and that it seems to be effective. So, he didn't go into a lot of detail about it, and I knew it was just speculation on his part, so I didn't really pursue it. But I was just surprised.
We're not seeing it as frequently as I would have hoped. I mean, we've seen the use of monotherapy, second line anti-androgens probably now for 3, 4, 5 years. I mean, the first guy was a patient of Al, I forget his name, with something with an L, who was a patient of Dr. O's, who was on monotherapy apalutamide. Remember, Len?
Yeah, Alfat.
Alfat, that's right. Alfat, no L's involved. Sorry. So since then, and I had talked to somebody about it or wrote to them about it this week. I can't remember. I mean, we've had guys on monotherapy abiraterone, monotherapy darolutamide, monotherapy enzalutamide, and by and large, they do better in terms of how they feel. I can't really say in terms of the results because it's so long term. We also know that some of these drug companies are now looking at clinical trials for monotherapy. So hopefully we'll have a blind, double-blind random trials with and without LHRH drugs. That would be easy to do now with the Orgovyx because you could give somebody Orgovyx and somebody a placebo Orgovyx. But I just would like to see it more used than it is, just from the standpoint of quality of life. And Bayer, we've been banging on Bayer's door to do it, and they're actually doing it now. They're in the throes of organizing a trial for monotherapy darolutamide. So this doc may be right. We'll see. We hope so.
Yeah, it's interesting. Not that long ago, when we were just experimenting with, hey, let's just try this as a monotherapy. Even though, just get your doctor to agree with it and try it. So we've this goes back a little bit to Dr. Jeff's opening comments about how ignorant most people are. I mean, we are, kind of a select group. Not only are we willing to try different things and go where no man's ever gone before, but we're pioneers. as advocates. Now the drug companies now they're running tests for monotherapies, whereas a few years ago we were kind of commenting that, hey, this seems to be working.
Yeah.
So this is a dumb question, but so abiraterone is an androgen receptor blocker, that type of thing would be. So the talk is that you can go to just that one and not do both.
So abiraterone is in the same general category as a second-line anti-androgen, but it doesn't block the receptors. It works in a different way. But yes, monotherapy abiraterone is something that we have had gents who have done it. So doing the abiraterone without an LHRH drug.
Okay.
And we've had guys on here, and we've talked about it. We have had guys on here. Ken Anderson, God rest his soul, was on monotherapy abiraterone for a long time, like 18 months, 2 years or more.
Yeah, I would say the rationale for Abby monotherapy is strongest because,
yes,
if you're using that, why do you need Lupron or Ogrovix? It's because they're all doing the same job, only Abby does it better. But I thought it was, I was a bit surprised when I got the results of my scan, and Dr. O said, okay, well, I guess you can go back on darolutamide. He didn't even mention ADT. So I prompted him, no ADT? He goes, no, I don't think so. And when I met with Dr. Guanciale here, she said the same thing. I said, you think it's okay for me to just be on Daro monotherapy? And she said, yeah, I don't see the need for ADT.
Oh,
good.
There you go.
Yep.
Vic, go ahead.
Yeah, I had a question for Len. What treatment or therapy were you coming off of when they gave you this information or suggestions to go with monodaro?
I was coming off of a 21-month drug holiday, Nick. Yeah. And before that, I was on Daro monotherapy.
So your scan showed more action? Is that what you're saying?
Yeah, I had 2 new lymph nodes, and well, there were 2 iliac bone lesions, but the SUV was like 3.2, and Dr. Guanciale was thinking, well, I don't really know if that's a real lesion or not, because that was awfully low. The background SUV was 1.6, so yeah, these are very small. But at any rate, you would expect that. I'm a Gleason 9. I was on no drug therapy for 21 months, so it's a trade-off. I said, okay, I didn't even think I'd get that far on the drug holiday before it started coming back.
Right.
Len, have you've restarted the darolutamide now, I assume?
Yes, I have.
How are you feeling?
I feel fine. There's a little bit more fatigue, physical fatigue, but other than that, nothing. No hot flashes, no brain fog. So it's the same way I felt before when I was on Daro monotherapy.
Did you go right to 600 or did you start at 300?
I started taking just actually 900, 1 in the morning and 2 in the evening. And then since I was feeling fine with that, I said, well, let me take the full dose. I'll add the second pill in the morning. And again, it didn't really seem to affect me. So now I'm on full dose and feeling fine.
Good.
Len, I had a question for you because I've been thinking about you today with this RB1 thing I've been reading about. Do you still show RB1?
It showed up in 2014 when I was diagnosed at MSK.
Right.
And the only other biopsy I've ever had was the bone biopsy at the NIH, and they only came up with one of the 7 mutations that I had originally, and that was 2019. So it could be because the bone maceration, destroyed the other mutations. I don't know, but you just reminded me, Rick. I meant to ask either O or Guancio, what about a liquid biopsy? Maybe I should have that
Right.
done.
I was just thinking that too. Whether
Yeah.
I do. Let me just quickly say, Your Majesty, how come you're on this call? We love to see you. We haven't seen you on this call for ages. Susan?
Well, wait.
Well, let me just explain to the guys that Susan was a regular. She was a regular on behalf of her late husband, Ron. And we loved having her on. And Susan is now our lead moderator for our care partners. But we don't have a care partners group tonight. To what do we owe this honor?
Oh, we owe this on because I thought it was tonight.
Next
Never
week.
mind.
Next week. But we love to see you. I thought you were going to tell us a bit about compassion and choices.
Say that again.
I thought you were going to tell us something about compassion and choices.
Oh, well, let's let you guys finish up. I'll have to, because I don't want to interrupt your meeting. Are you at the end of your meeting?
Yes, we're at the end of our meeting.
We are at the end of our meeting.
Finish up. I
We're
love
at
you
the end
all.
of our meeting. We're not at the end of our rope. We're at the end of our meeting.
That's good to hear. That sounds like something Ron would have said. All right, Susan and Ron signing off, and I'll try to come on earlier the next time if I catch it right, and we can talk.
All right. All right.
Good night,
Lovely
guys.
to see you.
You too.
Bye. Bye. And if any of your partners would like some support, we do have a really fabulous care partners group that Susan leads, and and there is, the proverbial Chinese wall. So whatever gets said in that meeting does not carry over. I'm in that meeting, but we totally respect the privacy of that meeting, and nothing gets said. And the care partners can come on and they can unload a little bit on in that meeting about what they're going through. We're happy to have them. And Susan leads that meeting, and she's fabulous, and that is a good meeting. We meet twice a month for that meeting, so it's on the first and third Tuesdays. The first Tuesday, no restrictions. The third Tuesday, no restrictions. The first Tuesday, we try not to talk about grief, and we don't talk about grief and bereavement, so that if there are care partners that don't want to address the grief and bereavement issues, they can come onto that meeting and feel secure. We do address them in the second meeting of the month on the third Tuesday. So with that promo. And the other things I wanted to raise have pretty much been all covered. One thing I did want to mention to you all, and I've been sending it around to the Brains Trust today, is that I heard a very good 20-minute discussion with Chuck Ryan and a researcher. And one of the things that came out of that was the fact that you may get a better result from a liquid biopsy than from a tissue biopsy, because what we're realizing is that I'd sort of realized this all along. It's kind of a no shit Sherlock thing, but the DNA that they pick out, the circulating tumor DNA that they pick out from your blood comes from all of the different lesions in your body. So they get a broader spectrum of your DNA than if they just went to any single lesion. And even if it's soft tissue, if it's bone, wherever, they would be only looking at one. Now, with prostate cancer, we generally think that other than neuroendocrine disease, the lesions, the mutations are all very similar across the board. There isn't a lot of heterogeneity between a lesion, say, in your pelvis and maybe a lesion on your rib, or in a lymph node. That's what the research has told us. But if there were to be any difference, the ctDNA is going to pick it up more quickly or more likely than a single site. Vic, did you want to say something about that?
Yeah, I was going to ask you. I think it was last week you were mentioning that you would probably avoid a Guardant liquid biopsy. Is that right?
Well, we've got a number of GU medoncs that we really respect that don't particularly care for Guardant, and they've
Okay.
told us so.
Yeah. Okay. I'm just curious. Yeah, what's going on with that? Thank you.
Okay, Caris, Foundation Medicine, Tempus, and there are newer ones, and some of the newer ones do more RNA than DNA, but the question is, how actionable is that RNA? But the one that we've heard too many times just isn't great and it's not coming from us, it's coming from the specialists, is Guardant. Okay.
Okay, guys. Thanks very much. Good evening.
Thank
Good
you.
evening,
Thank
everyone.
you.
Good night.
Bye-bye.
Good night, everybody.
Good night.
This conference